Hey everybody, it's Dr. Leith. We're rounding out the semester. We're almost there. I think there's probably maybe going to be one more video. There'll certainly be a sign-off video or a goodbye one. But we're getting towards the end of the semester. A couple updates. It was made clear to us that the summer will be online courses. So for those of you that are signed up in either of my sections, I have a diagnosis section and an assessment section. If you're wondering how that'll be done, it will be done online and it will be asynchronous, meaning that we will not have live meeting times. We won't be using Blackboard Collaborate. That doesn't mean that I won't meet with you via phone or Zoom for like office hours and things like that, but it'll be a kind of like what we're doing now. Do it at your own pace, everything up there. And of course, there's probably going to be a difference in how the courses are structured and stuff like that from my end, but that's just to give you a heads up. Today, it might sound like I'm a little rushed. My kids are here. They're upstairs playing. I've managed to buy myself a few minutes alone, so I'm gonna power through this before they come and overwhelm me. So today I'm going over emotional processing. And last time, or not last time, but over the last couple weeks, we went over psychoeducation, why it's important to inform your clients what trauma is and how it works and stuff like that. The biological aspects, what it is, what it means, the symptoms. We went over emotion regulation. We went over distress tolerance. Last time we talked about cognitive processing, so looking at the distortions and the thoughts. And now today we're focusing on the emotional processing, which sounds a lot like the emotion regulation. The emotion regulation was a lot of managing the intensity, and now the emotional processing is about working through how they feel about the trauma. So this is where you want to be when you think about, I want to work with trauma survivors, and you kind of have that picture of what does a counselor do when they do trauma work. This is what I'm talking about. This is what you're thinking. You're finally here. It dovetails a lot with the cognitive, so now we're balancing what are their thoughts, what are their feelings, and trying to work through all the symptoms. So we kind of hit almost all of them. Just kind of here's a picture of the gauntlet, right? We have all the components that we need to do our trauma work finally. And hopefully by the end of this, you'll be able to see how we tie it all together. Each of these components serves a purpose, right? One by itself is not sufficient. You've got to do the education. You've got to help them, give them the tools of emotion regulation, give them the tools for distress tolerance, process their thoughts, right? Mostly about safety, right? And meaning and things like that. So for you existentialists, the meaning making, the identity, all that good stuff. And now we go over the feelings, right? So anytime you talk about like counseling is inherently a cognitive process, right? When I say, how was your week? How have things been since the last time I saw you? What was that like? All of that's cognitive. It gets the gears going. You've got to think, whether you're pulling up the memory of what we're talking about or you're translating it so that I understand it, right? That's cognitive. However, and this is why we have the emotional processing, the cognitions evoke an emotional response, right? It pulls up a feeling. It's rare that a person has a thought without a feeling. And sometimes the feeling is just, it's muted or it's not very much, or it's a feeling of indifference. Here with trauma, though, we're talking about those negative feelings, whether it's fear or anger or despair. So how does emotional processing work for the person? So this is kind of what happens maybe in their everyday life, and this is certainly what you can do in your session. There's exposure to some kind of stimuli, right? Maybe they smell. I worked with a client who she was a victim of a violent home invasion. Her partner took her. This was years later. Her partner took her to a firing range so that they could learn how to shoot for protection. And the smell of the gunfire and stuff like that, brought back a ton of memories, right? So there's exposure to the stimuli, then the memories are triggered, right? Whether it's implicit, autopilot, or explicit, right? This is making me think. This smell makes me think about the attack. Either way, they're triggered. The memories activate emotions that were either encoded during the time of the trauma, so the fear, right? It brings me right back to that place of fear, or some feeling that gets conditioned with the memory, such as anger, right? So the summary of that part is there is some emotional sensation that's tied to that memory. The emotional responses ideally are then not reinforced, right? I'm really scared, and then I've kind of worked through it and I learn I don't need to be scared. So think of in your counseling office, you say, tell me about the disaster, and they start tensing up, they start getting nervous, and then throughout your session, they learn I'm safe. This feeling doesn't need to be here. I'm thinking about the earthquake, I'm thinking about the shooting, I'm thinking about whatever the trauma is, and this negative emotion is not being reinforced. And ideally, what you're doing, and what we're going to go over in a second, is counter conditioning those negative feelings, right? And that can take, it's the little things, right? It can be things like you're doing fine, it's reminding them you're safe, you're very strong to talk about this. They're being met with some kind of positivity that alleviates that negative emotion. And this leads to the extinction of that association, right? So those of you that have taken some sort of behavioral course or behavioral psychology course or ABA and things like that, extinction, it's when a behavior and association dissipates, it goes away. Think of the last time you lost power at your home. You probably went to your light switch and you flicked the light on and the light didn't come on. And then what did you do? You flicked it down and up again. And then you flicked it down and up again. And then you did the thing where you flip it up and down really fast and then you stop. And then you conclude this is not working. The behavior went extinct, right? So over time, the association between thinking about this trauma and the emotional reaction, the association goes away. That doesn't mean feelings don't exist. That doesn't mean the thoughts don't exist. It just means I can think about it without re-experiencing the emotions. So these types of emotions are called conditioned emotional responses. Throughout the rest of the presentation, you'll see me hyphenate them to CERs. And those are the associations between trauma stimuli, right? So smelling cigarette smoke, hearing a loud bang, hearing thunderclaps that then bring up the feelings that were associated with the original trauma. They can go extinct over time. Important to remind your client when they say, I don't feel like I'm ever going to get over this, will it always be this way? It can go away. It doesn't happen overnight. You can counter condition them in the therapeutic relationship. So I want you to think, what does this mean for practice? It means that as they're being exposed to stuff, as you process it, right? Because even processing, discussing the trauma is a type of exposure. You're re-exposing them to the memories and things like that, but making sure that they are safe, right? And it means that they're both physically safe here in the session. I don't have to worry about I'm going to be attacked here. I can talk about it here and my counselor's not going to attack me. But it also means I'm safe from criticism and invalidation, such as, oh, that's nothing to worry about, or why are you letting that bother you, right? So it means that we got to make the area safe and reinforce you're strong, you're doing it, you're doing exactly what you need to be doing to work through this. So memories are super complex. The Jim Hopper video did a good job of explaining that. Now we're adding memories and the conditioned emotional responses. And what typically happens is when you ask a client to talk about these things, they'll start going down different rabbit holes. It's not just going to be A, B, and C happened to me, and now I feel 1, 2, and 3. right? It's usually going to be a jumble of here's some attitudes, maybe here's some additional trauma. It brings up this is just like when I was younger, or this is what happened to a family member and things like that. And so as you process it, their mind's going all over the place. So what's important to remember is that their emotional response is not always at the forefront of their mind, right? This is where we're giving them that space, why we're giving them that session to help kind of flesh it out. The feelings can run in the background, and that's where you're using your counseling skills, especially the reflections, to help identify what is it that you're feeling, because they might not know, or it's so ingrained, or it's below the surface, right? It's subcortical, that they're having a hard time identifying the feeling. And the other thing is that your client can experience these conditioned emotional responses without being in session, right? They happen as the world goes on, as they're experiencing the world, and they can also go extinct on their own as they learn, and they will learn that I don't have to get angry every time X, Y, and Z happens. I don't have to get fearful every time this thing happens, but it goes much more smoothly and quickly in counseling. Take that with a grain of salt because I'm a counselor. So I said subcortical before. Here are the pathways, and those of you that had me in other courses know, like, I'm so not like a neuroscience person, but that seems to be the thing now. So subcortical, right? I get this sensory information. That information goes from my thalamus, which is the thing that senses the world around me. It then translates that, or it sends that information to the amygdala, which then gives me a feeling. And that feeling just exists, right? So I see something, I see a reflection in the mirror, I see someone that reminds me of my assailant, and I just have fear. I don't go through the steps of this person looks like that person, or this situation reminds me of that situation. It's boom. I see this thing, and now I feel this thing. Cortical, which is what you would do or cortical pathway is what gets activated when you're in session. So the sensing thing, your thalamus, it gets the information and it sends that information to your cortex, which is the thinking thing, right? And so again, when we're discussing, it's inherently cognitive. So now I'm thinking about the event, or I'm thinking about the memory, or whatever you're having me talk about. I'm thinking about it now. And then that thought, or not that thought, but in addition to going to the cortex, the thalamus sends the feelings to the hippocampus, where the memory activates. The hippocampus is your memory thing. And so now I'm thinking, I'm feeling, I got the memory, and then it goes to the amygdala. So I have the thoughts, the feelings, and the memory, right? So it's all very surface level, right? And that's where we're usually at in counseling. What do you need to know about this? That sometimes your client feels things and it's very implicit, and that's important for them to understand that in your everyday life, you're not going to be thinking about the trauma and the associations. It just happens and you feel something and that's it. In counseling, in your session, you're helping guide your client through this process, right? So what was it that set you off? It was hearing this loud bang, or someone banged on my door at 2 a.m. And then you're asking them questions. Well, what did you think? What was going through your mind at that time? Well, I was thinking this is what happened last time. Okay, and what happened last time, right? So now we're down to the memory. Well, what happened last time was there was all this loud banging, and that's when, some people broke into my house, and then you're at the place of, you must have been so scared. What were you feeling then? What are you feeling now? What's it like to discuss that with me? Intrinsic processing, we covered this a couple weeks ago, but remember, a lot of the symptoms for trauma, it's the body trying to process what happened. It's trying to rectify and consolidate all of this information. Complications arise when there's multiple traumas, when it's a systemic trauma, medical issues, traumatic brain injury, things like that. And so this is kind of addressing, well, if people can kind of have the associations go extinct on their own, then really what's the benefit of counseling? Well, one, you're a professional and you have training and things like that. But also sometimes the associations, the emotional responses are too much for the person, right? And it can also be too much in session, and that's where you got to learn how to back off and things like that. And re-experiencing things. This is what you're doing in counseling. When you work with someone who is a trauma survivor, discussing it is tantamount to making them re-experience it. The goal, though, is for them to re-experience it with fewer or lesser intensity negative emotions, and where they have increased control. All right. So before counseling, the client goes around and they might think, I can get through this. Maybe they even do some research. They get a couple workbooks and everything. And those are great. For some people, that is sufficient. There are also those people who, I tried doing these things. I've tried to work on my emotions and my thoughts on my own, and it's just too intense, and I can't do it by myself, right? I don't feel like I'm making progress on my own, so they make an appointment with you. And typically what happens is if a person is overwhelmed with the emotional response, they'll just avoid the trigger. So I just won't talk about it, or I won't go there. So now they're at your office. You help them re-experience the memories and the emotions and all that, but in a cathartic way, in a way that's going to help them heal. And you regulate the exposure, pushing and having them describe more or backing off as needed, right? And so that's what this model is. Very, not entirely different, but different enough from prolonged exposure therapy. With prolonged exposure therapy, it's just the same intensity all the time, right? So maybe a combat veteran has some PTSD stuff. What we're going to do is tell me about it in full detail each and every session, right? It's just constant across all our sessions, versus this other way that we're going to go over, the self-trauma model, which is much more of a let's push and then pull back, right? I need you to experience some discomfort, not so much discomfort that you run away, not so much discomfort that you start to dissociate in session, right? I, as the counselor, I'm going to say, okay, this was too much for them, and we're going to work on that together, or it's not enough. So to kind of pull this all together, let's talk about the therapeutic window, right? So the therapeutic window is a kind of theoretical thing. Obviously, there's not like a real window, but it's a midpoint between doing interventions that aren't effective enough and interventions that are overwhelming, right? If you have a client who is a trauma survivor and you ask too light of questions, right? Questions that don't evoke much emotion or thought, not much happens, right? It's kind of like exercising, but not exercising hard enough, right? What leads to us undershooting, right? What happens that a counselor would ask questions that are not evocative enough? Well, a lot of times is we're misreading the person, we're scared, we feel the questions are intrusive, we have some self-doubt, we have doubt about the methods, things like that, or we're just new counselors and we misread the situation. On the other end, you can go too hard, right? And that's when the client becomes flooded, right? This is where you ask a lot of questions. Maybe you ask them too fast. Maybe you start before they're ready, right? They came in for their first session, for their first appointment, and you dive like right in. They then get flooded with the emotions, right? You're not regulating enough. So now they start engaging in avoidance, right? They might dissociate. You'll start getting a lot of, I don't know, it was bad. I don't know. They'll start kind of pulling away, and then ultimately the experience for them will be that was too overwhelming. I'm not going to go to another appointment. So you have to control the intensity of what your client is experiencing in the session. And that everybody's different, right? You're monitoring their levels of activation. How engaged do they seem? Are they looking like they're really, really frustrated? Is this too easy for them? And it is a little bit of a balancing act. We want, as the session, as that hour moves forward, we want them to activate more. We want the intensity to kind of go up, and then we want it to come back down by the end of the session, right? So at the midpoint, the working phase of your session, that's where we would expect there to be, this is what we're focusing on. They feel some discomfort, not so much so that they want to run away, but enough that we're doing something productive. Overshooting is the concern, right? But it's very common. This is not anything to lose sleep over. You always want to do your best. Sometimes overshooting happens because there's co-occurring disorders with the client. They have tremendously high levels of anxiety. They might have some suicidal ideation. There might be substance involved, in major emotions, even for traumatic emotions, or recency, right? That they came in immediately, or maybe a parent or a loved one brought the client to you right after the trauma. And so it's so recent that it pulls up these major emotions, right? And that can be overwhelming, so they pull back. On the counselor end, we all want to help. And you meet someone and you say, I can really help, and I want so desperately for this person to feel better. And so you push and push and push, but it kind of pushes them away, right? It can be not reading accurately, which happens, whether it's trauma work or not. You will misread somebody, or there's some combination of transference and counter-transference stuff. So what does this look like? What does emotional processing look like? What are you going to do in your sessions? Well, here are the stages: exposure, activation, disparity, counter condition, and then desensitization. For exposure, it's just like it sounds. We are having them talk about the trauma in a graduated way, meaning systematic. So for all of you that have taken diagnosis before, if someone had a phobia, right, how would you work? Well, if someone had a phobia of a snake, you wouldn't just take them down to that snake farm off of 35. You'd probably start with, think about a snake, look at a picture of a snake, here's a rubber snake, and then take them to the snake farm on 35, right? You build up to it. Same here. So we would start talking about the trauma in a safe way, adding in more evocative questions as we move on. So we're ramping up over a number of sessions. You are using your professional judgment with all of that. Exposure here means having the client discuss the trauma. The exposure is to the memories and things like that. Different issues can come up as a result of this. They might have questions about why this happened or how this happened. Additional traumas, right? So as they're talking to you, they wind up saying, this is just like what happened to me years and years and years ago. And they want to focus on that. And that's okay. Let the client decide and lead what they want to focus on. Do they want to focus on getting closure with certain questions? Do they want to focus on the symptom management? Do they want to focus on the previous trauma? But we're exposing them. They came in and said, this horrible thing happened to me, and I'm asking, tell me more about that. What was it like? And things like that. At the beginning of your work, probably you could put it in with your informed consent. Most likely this will come after informed consent. Is explaining the benefit of exposure, right? This is what the process is going to look like. I'm going to ask you questions and ask you to talk about the traumatic event, and it's going to be really uncomfortable, and that is normal. That's to be expected, because that's how we get the change that we're looking for, right? This is asking a lot of our clients to talk about this really horrible thing. And there might be values, there are going to be thoughts and feelings and attitudes, but all sorts of stuff is going to come up. So we need to let them know that A, that's normal, and B, this is how we believe we can work through traumatic events. And then you can use homework, which we talked about before, right? The exposure might be, maybe they have a hard time discussing it in front of a person, having them write it down at home and things like that. Activation, right? So effective treatment means they're getting activated, which means as they're talking about it or doing their homework, they're getting the feelings, right? I start feeling scared, I start feeling angry, I start feeling whatever. It's those conditioned emotional responses. And so we need to find some way to help facilitate extinction among these emotional responses, right? And that might be that we counter condition with positive affirmations or information. It might be just a simple act of talking about it can be cathartic enough to cause some extinction. What we want to avoid, though, is avoidance. Avoid avoidance, right? If they start getting overwhelmed and pulling away, then we need to slow down and pull them back, right? We don't want them running from those feelings. That doesn't mean that we force them to experience it, but it means that maybe we need to do something to kind of pull them back and acknowledge that was too much. Let's regroup and try something less. So, how do we get activated, right? Well, we got to ask questions that will elicit those emotional responses. So, what were you feeling when that happened? What were you feeling? What was that like, right? And each of those is going to bring things up. And of course, you would also ask, pulling it back to present time, what is it like now? As you're sitting here discussing it with me, what thoughts and feelings are you having? On a scale of 1 to 10, how intense are those thoughts and feelings, right? But it's wanting to get some of those emotions so you understand what the emotion is. They're learning what it's like to experience it in a safe place. And if they start backing away, you start noticing there's some dissociation or some avoidance, you can validate and encourage, right? A simple, it's okay, you're doing great. I know it's a lot. You're working really hard. Stay with this. You're fine. You're safe, right? To help kind of encourage, and that is a form of counter conditioning in and of itself. So disparity. This is how we get to that extinction point. We have to reinforce that what the person is feeling. I feel a tremendous amount of fear talking about the trauma, and I see that that fear doesn't match the current situation. I talk about the combat I saw. I talk about the natural disaster I was a part of, and I feel all that fear and anger and loathing come up, or whatever it might be, and I see that it's not needed now, right? There's a difference between what I'm currently feeling and my current context, and so that's how we start making those feelings go extinct. The feeling happens, the person realizes it's not needed, the body learns it's not needed, and it starts weakening. It starts getting lesser and lesser and lesser, right? And so this goes back to what I said earlier in the video, that you have to establish safety with your client. And that means, first of all, safety from a physical threat, right? Talking about it here, you're absolutely safe here, but also safe from criticism and judgment that we're not. So think of if you're working with maybe a male survivor of a sexual assault, where there might be some fear of, if I talk about this, you're going to judge me. If I cry in session, you'll think less of me. If there's other cultural things, such as certain behaviors aren't supposed to happen before marriage and things like that, I don't want you to think that I'm bad or damaged somehow. So safety from that criticism and judgment. And then also, remember, these feelings are super, super intense. They're going to get overwhelmed, or they might get overwhelmed. We want them to know that even though it's really intense, you are still okay, right? The experience talking about it can be asking a lot, but you're still safe. Encounter conditioning, right? This is why I kind of said off and on throughout the session. So getting met with positive reinforcement. They might fear talking about, so a domestic violence survivor might fear ridicule or criticism, expecting somebody, because we can't control everybody else, they probably have heard this, why did you stay for so long? Why did you put up with that? Right? That's all invalidation. And in session, you're not going to do that. You're going to say something like, that sounds awful. It sounds like you took the relationship very seriously. you tried everything to make it work, right? There's positive reinforcement. You're so brave for sharing this. Thank you. That's counter conditioning. And then there's also this element of discussing things and is inherently cathartic, right? To get things off one's chest, to have a good cry, things like that. Discussing the trauma and then seeing that there's no negative outcome makes one feel as though they're safe and they don't have to worry. And then finally, we're at desensitization. So this is the end goal. I want to be super clear with this. The goal with trauma work and trauma processing is never to forget what happened. It's never to pretend that it didn't happen, and it's not to minimize what happened and for them to say, oh, it wasn't that bad. It is to acknowledge that it did happen, hear the person's thoughts, and hear the person's feelings. But it is the removal of those conditioned emotional responses, the conditioned part. A person is entitled to feel what they feel. What the thorn in the side for the client is that every time I hear this word or every time I see this thing, I immediately go into this place of panic, intense fear, intense anger, whatever. And it's that association that we're breaking, right? Or that they're breaking. The triggers will then become less powerful, and eventually there are just memories. This did happen, and I am okay, and I'm safe, and I'm a strong person, and I'm managing. So just a few points to wrap up. One is the use of EMDR. What we talked about here today is not terribly different from what you would do with eye movement desensitization and reprocessing. That has a lot of validation to it, a lot of good research on its effectiveness, but that is a form of doing this where we're talking about, tell me in detail about your trauma, and we might chunk it over several sessions. Tell me in detail about this traumatic event, give me a feeling word for what you're feeling, and then trying to work through it. So we're processing the trauma, we're acknowledging the feelings, and trying to change those associations. And some clients might experience hotspots. This is what I was referring to earlier, where the person, as they're talking about a recent trauma, they then also start talking about a previous trauma or some other complication, how it's affected a relationship, or you might hear someone say, I just can't get past this one piece of it, right? Let them flesh that out, right? That just might be a block. So there's a part of the trauma or a part of the story that they're not stuck on. That I think that's being too harsh. They're being too hard on themselves. But there's a part that they need to process before they can process the bigger or overall experience. So then let them focus, follow their lead. If they want to focus on this one detail, give them the time and the space to do that. It serves a bigger purpose in getting through the rest of the narrative. And then substance use. Many people will use substance to quell the trauma symptoms, and we talked before about that can be problematic in the sense of it lends itself to re-traumatization and things like that. Again, if they're using substances, that might be a form of avoidance, so we might do like a chain analysis or something to see what led to that drinking or drugging or behavioral use, right? What was it that you were feeling and thinking that led to all of that? That's going to do it for today. I hope that wasn't too jumbled. I will post some material on Blackboard. I hope everyone's staying well and staying safe. I miss seeing you guys. Please let me know of any questions or concerns you have. I'll post at least one more video. I hope each of you is doing well. And thank you so much for your patience. And I got a lot of supportive emails as we transition. Thank you so much. That was very encouraging and very, very validating. Thank you for validating my feelings. I hope all of you are well, and I will talk to you again soon. Bye.